to go through the human endometrial epithelial cell layer. So this is a very exciting and fascinating image because this is how life basically started for all of us. And we all, at some point in our development, looked like cells. Just like these cells. Okay? So, in this talk we will explore how the maternal immune system and embryo communicate during the implantation stage, especially in IVF, to show that this communication is a very complex dialogue that involves immune cells, cytokines, overview of what we will be discussing. The interaction of many cytokines and immune cells will be discussed. We will go over the basic concepts of chemotherapy and implantation. This is for us to understand the dialogue of the immune and embryo interaction, which help address implantation failure in IVF. Basically, the ultimate goal is to integrate immunological insights to improve IVF outcomes. In general, embryo implantation consists of processes such as the image here to your shows you what we see in the laboratory and what our clinicians see in clinic in preparation for embryo transfer. But what happens in vivo is actually the blood process have to orient itself in a process that's called acquisition and find a place where it will implant and attach itself to the epithelial cells and then start the process of invasion, which finally is concluded with a full implantation. Generally, we know that the blood is composed of two types of cell layers: the inner cell mass, which is the couple of cells that will give the fetus, and the trophoblast cells, which will give the placenta. Establishing general concept, the only part of the embryo which comes in contact with the maternal immune system is the trophoblast cells. Okay, and what is very interesting is that the trophoblast cells, which contribute to the formation of the placenta, very interestingly, many genes that control the placenta formation are derived from paternally imprinted genes. This is really fascinating because we are talking about an organ that comes into direct communication with the maternal immune system. Majority of the genes contributing to the formation of this organ comes from the paternal side. The lecture will focus on cellular dynamics of embryo implantation, which involves precise hormone regulation. Basically, it's not two cells that come into contact with each other. As you can see, there's so many different types of cells in the residual that come into direct contact with the human trophoblast cells. What happens after the embryo completely implanted itself? You see the orange circle there on top of the embryo must completely implant. Trophoblast cells start to differentiate the different types of cells. There's two pathways in the invasion and synthetic trophoblast pathway. They start the process of immunotherapy remodeling. There is cellular differentiation, maternal immune adaptation, inflammation, to reach the final goal of maternal fetal immune tolerance. So this is on the cellular aspect, which you can see very clearly the different types of cells. But when we go to the gene level, what is extremely interesting that has been shown in this study is that many of the genes that are expressed at the time of endometrial receptivity are actually related to immune regulation genes. So this is highlighting the importance of immune factors in embryo implantation. Disruptions in these immune responses may contribute to implantation failure, highlighting potential targets for therapeutic interventions in ERT. So why understanding embryology the IVF? Well, because it is reported that at least up to 35 of euploid embryos fail to implant. So from the embryo side, we have a chromosomal euploid embryo, and we have accepted endometrium based on hormonal analysis, but the pregnancy doesn't continue and there is a failure in implantation. So this means it's not only the embryo, and it's not only hormonal factors that contribute towards the success, but there are other contributing factors that could be related to immune modulation. Again, we go back to the whole concept that we established just now. It's not two types of cells. It is a combination of many cellular components that synchronously and precisely coordinate their talk and communication to establish a receptive environment for a successful pregnancy. As I showed you in the figure earlier, there's so many different types of cells in the residual. 50% of the cells at the time of implantation are actually related to immune cells. And all types of immune cells are existing in the uterine epithelium at the time of implantation. Any irregulation in the balance of these types of cells will cause either implantation failure or a miscarriage later in pregnancy. But we need to establish a successful balance between all these types of cells for pregnancy to be successful. One of the most important cells that is driving implantation is actually uterine NK cells, which are different than what is found in the peripheral blood. They are characterized by having low cytotoxicity. They produce high amount of and different types of cytokines and growth factors. They constitute 70% of the immune cell population. Before talking about the uterine NK cells, there is one important immune cell, which is the dendritic cell, that actually starts facilitating the implantation process. And what the dendritic cells does practically is that it removes the physical barrier from the endometrium, which is called a mucin layer. So it releases factors to dissolve that layer and supports the implanting embryo in exposing receptors that have the embryo attached to the endometrium. So attachment is immune regulated. If there is any defect in the dendritic cells, then we expect that this mucin layer is not released and embryo will not be able to implant. As I described earlier, the uterine NK cells, they play a massive role in the modulation of the implantation process by promoting desensitization of stromal cells before implantation, by regulating immune tolerance at the site of implantation, and by facilitating trophoblastic invasion and vascular remodeling post-implantation. Now, one very interesting study that has been published very recently actually has done an interesting, has profiled patients' receptivity based on their immune profile. So what they have done, they carried out a study where they put patients into two groups based on their immune profiling. What they did is that they put the patients into two categories. There's a control group that doesn't have any problem with implantation, and there's another group that they did immune testing by taking a biopsy and the quantitative PCR analysis to classify a profile of the endometrium. And they came up with 4 subcategories for this profile. So they have a balanced endometrium in terms of immune system, and they have an underactive endometrium, an overactive immune endometrium, and a mixed profile. So the patients with a balanced immune profile, they did not have any immune interventions, so they went to IVF as a normal protocol. But the patients, when they detected an underactive immune response, they had low uterine NK cell count, and they made a protocol to tackle the activation of the immune response in this population. For patients who had an overactive immune response, they tried to dampen the response to reach a neutralization stage of the immunity. They identified a mixed population where they couldn't distinguish between the immune response and the immunity, so they classified it as mixed, meaning that these patients had the two extremes, high plus the low activity of uterine NK cell support. Okay, so just to walk you through, the ones that were in the conventional care, these are patients that went standard embryo IVF treatment. The precision care, so this is a personalized care, patients received tailored interventions adapted to their immune profile before going into the transfer procedure. The management strategy for the patients with underactive profile, what they did is that they tried to enhance the immunity by doing endometrial starch, by giving a low dose HCG, and standard BTS support. In the overactive immune profile, they gave them the strategy for the intervention was using glucocorticoids, interlipid infusion. But what they did first, they administered the glucocorticoids, and if it was not effective, they went to the interlipid infusion. So the second line of immunotherapy was used for patients with profiles that didn't normalize with the steroids at all, so they went through phases. They also increased the dose of progesterone, and for patients who did not normalize, they had to test if the management was effective before proceeding with the transfer. If it was not effective, they will add the steroids or the antibiotics. The outcome, as you can see in this figure, was mainly that live birth was improved, especially for the patient population in the overactive and underactive, while the patients with the mixed immune profile did not benefit as much. What is very interesting in this, if you see the embryo based on the embryo quality, the patients with suboptimal embryo quality had a significantly higher rate of live birth with a suboptimal embryo. So this is really a highlight basically to us as embryologists and clinicians, because we know that an embryo with suboptimal quality will give us 20% chance of pregnancy, but according to this study, it gave 36% chance higher. So basically, the summary is that before proceeding with embryo transfer, they had to study the endometrium immunologically. Is it receptive or non-receptive? Is it over? Is there an over-inflammation, under-inflammation, or is there a mixed window of inflammation? So by characterizing the status of the endometrium, they have to manage the over-inflammation or under-inflammation before proceeding with embryo transfer. And they did this for patients in the mixed group of implantation failure and those that didn't have implantation failure. And their main outcome is that this intervention benefited patients from the first attempt of IVF. So why do we have to wait for patients to have implantation failure when we have a clue about the endometrial status from the immune perspective? Moving forward, so that's the side of the endometrium. From the side of the embryos, there are some studies that have looked at growth factors or cytokines, or in some study they added melatonin to embryo culture media. They found some positive effects on cellular proliferation blastocyst formation or high replication rate. But what I would like to highlight is that before applying this into the clinic and into the culture system, we need to look at the cellular mechanisms and molecular mechanisms that these factors activate when embryos are exposed to them. In all the publications that I have looked at, I've seen one publication that mentions a negative effect of adding GNCSF to the embryo culture system, which at high concentration disturbs the embryo lineage specification in the protective. So this is something that we need to be cautious about. And if we introduce any animal treatment and expose the embryos towards it, we need to understand not only its effect on proliferation of blastocyst formation, but we need to understand the basic biology of how these cytokines work and what is the downstream effect. So where next in terms of reproductive immunology? From these studies, we need to define the immune diagnostics. Now, the study that they showed, what they did is that they took biopsy of the patients before the embryo transfer. But is there another way that they can take maybe endometrial fluid, which can give them the same conclusion, something that is less invasive? Targeted immune therapy. So you don't use anything for anybody. You have to tailor the treatment. You have to really study the case individually and not to try anything. And finally, the studies that are coming up can integrate with AI to produce models to provide a precision reproductive medicine approach that will combine immune factors, gene expression, genetics from the embryo to model the treatment and to say, yes, this cycle, the endometrial is receptive from the immune, hormonally it is ready. We have the embryo, go ahead and transfer. The model can also help us decide that it's not a good cycle to transfer an embryo. So a patient with one deployed blastocyst should not lose that blastocyst. So the decisions to go ahead and transfer, we should look for models to help us support these decisions. On a final note, I wanted to bring everybody to the subject that pregnancy is a unique immunological condition. So a pregnant woman doesn't necessarily have a weak immune response. On the contrary, immune system during pregnancy is very strong. Evolutionarily, it has to be strong. If you think about it, any infection or pathological exposure would actually lead to the death of the mother and the baby. So evolutionarily, the immune system during pregnancy had to adapt itself to be strong and more sensitive and resilient to pathogen and to balance the response and to infection and to maintain a semi-allogeneic fetus that is not completely similar to its composition. And what happens during very early stages of pregnancy, this is the take-home message. During the stage of embryo replication, trophoblast invasion is a key step to what will happen later in pregnancy. Any abnormal process that can go wrong, any abnormality in the invasion can be translated to preeclampsia or small gestational age or any other complication at the end. So when we see cases of preeclampsia, when we read about the literature, I often think and go back to what happened during the lactation, what happened during the first weeks of pregnancy and placenta development. So the take-home messages is that embryo plantation is an immune balancing act. Any dysregulation contributes to ideal failure. Individualized assessment